then we will join. Then we will officially start our Friday forum. Thank you all for joining. We are live streaming on YouTube. We also have, we will be recording, so the recording will be available for you as well. Please use the chat. The chat is open for anyone to put in any comments. We're looking forward to, the sun has just come out here in Canada, so you can see me in a funny way in the screen. I will put up the screen, my curtain soon. If you want to use subtitles, you can use the buttons in the screen to get some extra support. We are still admitting a few last minute people and our panelists. So I'm really happy that we're here today. So if you can give me 1 second, because I cannot see anything anymore. Just need to quickly open the curtains. Sorry, I should have been prepared for that. Here we go. Okay. Thank you all for joining our Friday forum. Today we have a really fun debate, and I'm so glad that I have a wonderful panel of people that will be talking to each other about how and whether we should refer from private providers any clients that have issues with symptoms that are related to TB. Should they be treating them? Should they be testing them themselves? Or should they actually refer to a public health facility and a public TB facility? So we'll be looking into that topic. Before we get into that topic, and before I introduce our wonderful panelists, I want to just briefly share my screen, and so that you have a background on the topic that we are trying to present, while I'm admitting our last people here as well. So all the panelists are here. We have a wonderful group of people joining. Thank you all. Please use the chat, use the subtitles. I'm so glad that you're all here. Thank you, and for registering. I would like to share a quick slide, and that gives me also a way to introduce the speakers to you and who we have on the panel. So I'm hoping that you can see my screen. And I will display settings. Here we go. Now you should be able to see my screen in full. So with us today, we have Dr. Erlina Burhan, who is a private physician in Indonesia. She is a chest physician in a hospital, and she's also a principal investigator in some of the very important research related to new tuberculosis drugs, especially drug-resistant drugs. And she's very interested in being involved in many of the other, she's leading many initiatives in Indonesia. We're very pleased to have you. She's a strong advocate for engaging private providers. Thank you, Erlina, for joining us. We also have Dr. Neha Rastogi, who is with us from India. She's a chest physician in New Delhi, in the AIIMS hospital. She has background in many infectious diseases as well as in tuberculosis, and she will represent the voice of private providers, and she's engaged with her hospital in many TB initiatives in India. Then, to advocate and to hear about the public voice, we have two wonderful colleagues. If you can please mute yourself if you're not speaking, that would be really helpful. Thank you so much. So with us today is Dr. Obioma Chijioke Akaniro, sorry, Obioma. She's the lead in the national TB program, TB and tuberculosis and leprosy program in Nigeria. She's the lead on monitoring and evaluation. She's a very strong voice within the program, and I am excited to hear her points advocating for the public program. And as well, I'm really pleased to invite and to hear the voice from Nikrotimi Rigi. She's in Kenya, in the National TB program in Kenya. She's the lead on PPM, public-private mix, within Kenya, as well as on gender and many other topics. She's a really strong voice within Kenya, and very pleased to have her. And then last but not least, pleased to introduce our wonderful moderator, Dr. Rakesh PS, who is with us. He's a lead within the union in the Southeast Asia Union in India, as well as a thought leader in public-private engagement. He has initiated together the STEPS initiative on engaging private hospitals within India, which is a fantastic program. They're also looking at the corporate pledge on engaging private hospitals. So with his leadership and thought, he's going to be our fantastic moderator for today. And we'll be hearing both sides closely. So now I would like to just to set off the debate that we're talking about. You can see that we're talking about, should private providers really refer all their symptomatic clients to the public sector? So to set us off a little bit, I wanted to show you two scenarios of the reality. Often it is when we have a person who has TB symptoms, they go to their closest by provider, their trusted provider, whether it is the village doctor around the corner, the pharmacist, the drug seller, or it is a small facility in a neighborhood or in their workplace. Often, those people are not directly connected to the National Tuberculosis Program. So one option would be is that they get the information that when you see any symptomatic patients, please refer to a tuberculosis center. That's where the specialty is, that's where the quality is. In reality, what that means, people hop around. There's many delays in the pathway. They get maybe tested for something, but not tested for TB. They don't have any transportation costs to go to the referral center where they need to go to. So there are lots of barriers and problems that deal with this referral, and we will hear about those. If the private provider says, I will treat by ourselves, what we know from data, often that means they actually treat with cough medication. They provide a whole bunch of tests that are not necessarily the TB tests that give us the outcomes we need. There's high out-of-pocket cost, and the over-the-counter medicine has lots of other problematic parts with it. And on top of it, they're not being notified or reported. So those are the two scenarios, and those are the realities that many of you probably are aware of. And we're going to hear from both sides, the public and the private side, on how we can better do this work. So I'm going to stop sharing, because right now I'm going to hand over to Dr. Rakesh to lead us off in this wonderful debate, and I'm looking forward hearing both sides speak. Thank you so much for this fantastic event today. Go ahead, Rakesh.
Thank you. Yeah. Thank you so much, Petra. I'm also excited to be here to hear about all the experts who are sitting here. I mean, we're very excited to see Alina, Neha, Obioma, and I mean all the panelists here, Nicote, all the panelists here. It's a very important topic that we are going to discuss today, so I don't want to waste the time of the audiences generally. So I'll just directly get into Erlina and Neha, because they are the private providers. They are from two high burden countries, India and Indonesia. These are the two high burden countries as far as TB is concerned. So they are the private providers. So my question is basically to begin with Erlina and Neha. So as the private providers supporting people in their TB journey generally. So what makes you most passionate about the role of private providers in the tuberculosis care? So what is making you more passionate about the role of private providers in the tuberculosis care? We will try to be as brief as possible. Maybe I will first hear from Erlina, then we'll go to Neha. Or to Erlina.
Okay, thank you, Rakesh. Can you hear me clearly?
Yes, we can hear you. We can hear you.
Okay, thank you. So first of all, I would like to be very honest and frankly with you all that I don't like the title of this topic right now. For me, it's really something that look down on the private provider. Why should we refer all people with symptomatic to public sector? I don't see any significance of doing that. So yeah, just by having that title, it make me more motivated to stand for the private provider. Yeah, in my whole damn life, I've been working with 2 private hospital. Yeah, and most of my patients are TB patient. Most of them. I'm have a good interaction with them. We talk. I'm not only telling them what to do, but I also ask them what they like, what they feel, and everything. And we have such a good relation. So it makes me more uh, make me more motivated to improve the condition of private provider. Yes, I know that many of private providers or private clinic are not that having a good equipped by all the facilities. They have many unfortunate situation in terms of infrastructure. For instance, not all of these private hospital have a good diagnostic tool. For instance, nowadays we are talking about rapid diagnostic that recommended by WHO. Let's say expert, TrueNet or whatever. And many private hospital, they don't have that. They're still doing acid fast bacillus testing or microscopic testing. And the public sector, you guys get all the facility, you get the drugs, the TB drug that even covered by the government. Your patient in the public sector get the free facility. The drug are provided by the government, but this is not happening in private sector. Patient has to buy the drug from the pharmacy. So for me, this is not fair. But the reality is really sad that people tend to blaming on this situation. I think this is really not fair. No need to blame. Instead, you need to support, because in terms of competency of the doctor, we have the same competency. We know how to diagnose. We know how to treat. Yes, of course, there are some doctors who are not really updated on the new update, let's say the new guideline, everything. But there is also the responsible of the government to upgrade the knowledge and also the competency, but not blaming. Please support. Yeah. So
Thank you.
in many situation in Indonesia, I'm talking about Indonesian situation, many of us are the double agent. In the morning, we do practice in the public sector, and then in the afternoon or evening, we do practice in private. We are the same person. We just good as we are either in public or in the private. What make it different is the facilities. I think I have to stop now and offer to
Thank
you.
you. Thank you so much, Erlina, for passionately speaking about for advocating for the private providers. And you rightly said that, okay, the relationship is something which you really like, and you are saying it's actually difficult to differentiate between public and the private generally, as you rightly point out. Same doctors may be practicing in the public sector, same doctors may be practicing in the private providers also. That's what you try to highlight. And you also said, okay, private providers know how to treat. Okay, agreed, great. Neha, what is makes you more passionate? I mean, maybe 1 minute we need to tell what is your passionate, what makes you more passionate about the private providers journey in.
So as Dr. Elena has mentioned, even I had a transition from government to private, and I just want to say that the entire thought process is, be it a private, be it a public, the TB, tuberculosis for one patient is its private affair. So even if the patient is in the public or the private, for the patient, it is a privatized affair. Patient needs a personalized care. Patient needs the customized care. So be it a private provider or a public provider, and I believe as a private provider, we are more part as well as partner in their therapy. So it has to have a proper access, and each and every time an easy approachability, a proper customized, because TB is not about putting up a drugs in the bucket and say that, okay, you have to take it for 6 months. You have to step by step handhold the person. You have to go about then their journey. So in that scenario, I would say the personalized care which we as a private sector would provide is good. But having said that, the idea of the debate is actually to dissolve this debate, to have a collaboration between the public and private, so that, as ma'am has pointed out, the access and affordability is also not an issue. And of course, that individualized approach, which is a very, very important hallmark in the tuberculosis, seems to be on the priority.
For putting forward that point. Maybe from two different countries, India and Kenya. We have Obioma and Nikoke. So maybe we know that. I mean, in your country, basically what we have actually seeing is that private providers play a very important role.
Okay, I will take over quickly because I think Dr. Rakesh lost. I will pin him back in when he comes in. But in the meantime, Rakesh, go ahead.
Yeah, sorry. My internet connection is a bit stable. So I was just talking Obioma and Nikote about you make so many efforts to engage the private sector. You make so many effort collaborate with the private sector. So what make you want to engage with them, or else the question is what makes you not want to work with them? So maybe in 2 minutes, if you can explain Obioma, I mean, we'll be happy to hear that.
Okay, thank you so much. And I was glad to hear my co-debaters. I really feel that even from what they are saying, they are already somehow supporting the topic. Somehow you're supporting the topic, and I would prove you the reason why you're supporting the topic. But to go straight to my to the question, for me, the reason why private sector engaging them, it's good, is because one, care-seeking behavior, there are some that would really prefer the private sector. And if you, in my country where we have 60% of our patients who would want to go to the private sector to seek care, means that if you don't engage them, there are some of those people that you may miss. So to ensure that they have also quality care within the private sector, you just have to engage them. That's it. So it's more like it's because we have to ensure, in the spirit of universal health coverage, to improve access, you need to get to these people. But, you know, the private providers, they are gap fillers for the government. If the government is able to ensure that we have enough reach in terms of the hospitals and facilities for these patients, and we're able to expand those facilities within this place, you will see that the private sector is actually less, the public sector is actually easier and better for these patients. The fact that I'm not against the private sector, but the topic, if you look at the topic, what it says identify and refer. And if you know that in the models of care for TB services, there is a point where we have identify and refer. So what we are saying is that, can this identify and refer? We still have the private sector. You do identify and refer. If within the people who come to you, there are people there who you feel have the symptoms, can you just send them to us for us to continue management? So we have also given you an aspect of the private engagement, which is identify and refer. Then if you look at some private sectors, you will see that even in engaging them, there are some of them who also don't want to deal with TB, and they will tell you, I would rather want to identify and refer quietly. So you will still have some of them that want to stay in that aspect. So if you look at coming to management of patient, how many of them actually want to? So the stigma aspect is still obvious there. And the fact that they are profit-oriented, and we want to encourage and have, TB is a disease of the poor. How do you do that? You know, for disease of people who are mostly poor, among that. And you have this private sector, which is established basically because of profit. It's not like the government sector who have a lot more things subsidized. So what we are trying to do, if we have to prove universal health coverage, we have to deal with reducing out-of-pocket expenditure. We should be thinking of identify and refer from the private sector. So everything that UHC preaches is involved in the public sector. Now, getting a private sector, getting them involved in the insurance and all that, you need a lot of discussion, and the aspect of substandard things are going into it in terms of them to also make their profit. So there are reasons why we want to engage. The fact to ensure that in terms of universal health coverage, we cover a lot of patients, and the fact that we still have those who will seek them. But there are also reasons why you want to keep it at identification and referral. Thank you.
Yeah, thank you. Thank you so much, Obioma, for saying from the point of view of a program manager and how you see private sector as, and how you see it's important, and what are the challenges that you really face. We would love to hear from Nikita also for a minute. Nikita, over to you.
Thank you very much. I'd like to pick it from where Obioma left. And it's quite interesting. I remember the last few months ago, and we were in this very forum, and with Alina, we were speaking about the trust of the private providers to the government, and vice versa. So this trust, the discussion that we started off for trust needs to continue. Both parties really need to trust each other. So I'll give an example from Kenya. So we realize that majority of our service providers are actually private. And as Alina said, yes, a patient will still choose to first seek care where it's available. And this is to the private facilities that are nearly there. But are the private facility willing to comply to the standards of the government and to offer services? So the government is willing to most of the time support, quality care through training and offering standard tools. But as Obioma says, the private sector is there for profit. So sometimes there's that issue. But honestly, what we need to focus on is having a task mix that allows those that can screen and refer, then they do that, and refer to the either. I'm an advocate of either, both public and private facilities where they can get services. So if you're a level of service provider whose only capacity is to screen, then screen and refer. The government facilities, and I mean, because of maybe where our countries, where we are from, we find it, some economical to first equip the public facilities. So you'll realize that most public facilities have the gene experts, TrueNut machines, and other diagnostic mechanisms. So if our sample referral mechanisms maybe are working, then you can collect a sample at this site and refer to a diagnostic facility. But if the private facilities, again, are willing to trust the government, we can work seamlessly to ensure then that the referral pathways are very clear and are serving the purpose why we are doing this. At the end of the day, we are looking at the universal health coverage. And for us is to ensure then we do not continue to put a pain on the patient's pocket by increasing the costs on them. So if we can screen and collect sample and refer them, that's beautiful. Where we can diagnose at site, that's okay. But also it's very important that we make investments and be very candid about making investments where we see that our patients are going. So like if we do patient pathway analysis, like in our country, we realize that 42% of our patients first go to the private facilities. If we really are interested and want the universal health coverage to work, then we need to meet the patient at their first point before it's too late for them or before they have advanced disease. So therefore then, as we focus on equipping the public facilities, it's also important that we equip the
I'll come
private
back to you.
facilities as well.
We'll come back to you very soon. Thank you so much
Yeah.
for raising these points. I mean, you brought out so many important points. Again, I am just placing the debate question right away again. The question is, private care providers should refer all the symptomatic clients to the public sector. This is our debate question today. The private providers should refer all their symptomatic clients to the public sector. So we would love to hear the exact points, the arguments that you want to put in. All of you have actually started putting in all the arguments, but if you want to consolidate the points, maybe I will go to Obioma for 2 minutes, again come back to Nikota for the 2 minutes. You can have your arguments against this or for this. Private providers should refer their symptomatic clients to the public sector. You can have your arguments for this. Over to Obioma for 2 minutes.
Okay, so starting off from where I stopped and also picking up also from some things that Coretta said, let's look at, we are talking about patient-centered, and in being patient-centered and looking at the population, for my country, malnutrition is the highest in terms of the risk drive, and malnutrition, undernutrition, go hand in hand with poverty. Means that a lot of this happens around poor population. So we're not even having the private sector to refer their symptomatic. I think it's something that we should be discussing in such setting where there are hidden causes within the private sector. Let's also come to the point of comorbidity. Those of them who are comorbid, you know that the public sector, we have a lot of specialty being paid by the government who occupy different clinics. So it's always very easy to have this referral of someone who is comorbid for one thing or the other, has a heart disease, has a chronic respiratory disease, one thing or the other, that might actually need the patient to spend more. Imagine having this patient within the private facility and having to spend more. Or will you say, oh, within this private facility, let me treat the TB and send him to this place where he needs to spend more. So if you're looking at totality of the patient and what they need to spend, in terms, because you don't even know what the outcome is when you've diagnosed, the more you deal with the patient, the more you say what the patient needs. Having this patient in a place that is profit-oriented, you will see that these patients will drop off. And that's why we'll start having loss to follow up. We'll start having people who don't finish up their treatment because they can't continue. And they will relate to every other aspect of treatment, maybe local treatment around the corner, something that can help it because of the funds. So, but within the public facility, you can have referral to all those special clinics. And also, it's within this public facility, that's where we have the medical trainings going on, like the students who are being trained, medical students. And this is where we now foster the next generation of people who will manage these TBs. So they also need to have the experience of these patients within the public sector. There are so many things I can say about that, but...
Thank you, Abhyama. I mean, we'll get a chance again. I mean, thank you for raising these two important points. You spoke about the spending more from the patient and also about the outcomes and drop-off or what we call as the loss to follow-up sort of stuff. Again, Nikrote, I mean, again, 2 minutes for you to put your arguments. Say, private care providers should just refer all the symptomatic clients in the public sector. What are your arguments for?
Thank you. Really, the same thing again, Obioma said. If we are really interested in the patient-centered approach, really, we need to focus on the fact that we need to meet them at wherever they are. The patients need to have an opportunity, yes, to be attended wherever they are, irrespective of where they're seeking care, but then get quality care services wherever they are. So what am I saying? Yes, either way, we should have support whoever is providing services to be in a position to offer those services. If the private provider is in a position to offer comprehensive services, then yes. But if not, screen and refer. Thank you.
Thank you. Thank you so much, Nikrote, for putting your points favoring why should private providers just refer the symptomatic clients. Now let's hear from Erlina and Neha what they have to say against this. Maybe I'll go to Erlina first, then to Neha. Erlina, what are your points saying that this is a wrong argument? Over to you, Erlina.
Well, after listening to Obioma and Kirote, I'm probably will say a bit something that try to compromise. So let's refer to
Can you excuse me?
oh, I cannot.
Yeah, Erlina, now you can continue, please.
Okay. All right. So let's talk now. I think the private provider can have some compromise. Yeah. After listening to you two. But still that that is not fair to refer all the people with symptomatic to public sector. Why? Well, Obiama said about TB is the matter of people-centered approach, right? And these people are very unique. They are not robot that you can say, go there, go there. No, we have to ask them. We have to talk with them. In my situation with my private hospital, 100% I will not refer. Okay, because in my private hospital, we have all the facility. We have chest x-ray, even CT scan. We have diagnostic tool, expert or acid-fast bacilli. And we also have the drugs. We have a government drug which is free, but we also have a branded TB drug that in the pharmacy. So I mean, I will not refer my symptomatic patient unless they decided, yes, I want to be treated in a government hospital. Because you said it's a people-centered approach. By saying people-centered approach, we have to discuss with our patient to make them comfortable. Otherwise, we will miss the patient. You said about loss to follow up. If we force them to go to the public, which they don't like, they will not go, and then we have initial loss to follow up. But yes, in the condition of the private provider who doesn't have enough resources, we can offer the patient to go there, but please make sure and tell them that this is for their own sake, that we have to send them to a certain public facility because that is what that being need for their treatment. But
Thank
yet
you.
yeah, but I mean, let's communicate, just talk between the private and the public, which usually does not in place. We just blaming each other. We don't talk. We don't really talk. Yeah. So in the condition of, let's say Obiama said that in the private sector, there is not enough facility, there is no expert and no drugs. So the patient need to go to the DOTS facility. Hey, listen, in the country like Indonesia, more than 50% of the people, they goes to private facilities. Less than 50% they go to public facilities. So why don't you guys, the private hierarchy, make the facility in private to become a DOTS clinic instead of refer them. Okay.
Yeah. Thank you, Erlina, for raising that important point. So Erlina's biggest point was like people are coming to the private facility for seeking their treatment. And we need to ask them before referring because they came out of their own choice. So we need to ask them. This is the point that Elena was trying to put in place. And she was also trying to say that, okay, we have the systems, then why should we refer? Right. Neha, over to you. What is your argument?
Right. So actually, Obioma herself has stated in the beginning that 60% of the patients initially come at the private center interface to get their symptoms diagnosed. And as the topic of the debate is all the symptomatic patients being referred, all. First of all, it's never an all or a none phenomenon. And then second thing is if the majority of the patient, as per her data, and even the Nikrote also said that if the 60% patients are upfront coming to the private for the first and the most crucial step, which is the intensive case finding, if that is being done in the private and then being a patient-centric disease as well as the approach, if they have been identified there and if they have a facilities, because it's not like that, as Dr. Elena has also mentioned, and thanks to the steps and the programs of the TB elimination nowadays, we have a lot of collaborative approach as well. So if the patient identification is done in the private sector, if the asymptomatic or symptomatic has been done in the private sector, if the patient wants to continue in the private sector, the idea of putting up all the patients in the exclamation marks doesn't stand hold and true, first of all. Second thing is, as we mentioned, that the majority of the times the patient do have their access and affordability and reach to majority of the drugs, even the diagnostic services, both through the decentralized system as well as the linkage system, which is there in majority of the countries which we are belonging to, that diagnostic initiatives, as well as making them symptomatically diagnosed, reaching out to the diagnosis, the large scale availability of the drugs to the most of the care centers. And just to answer one very important point Dr. Obioma raised about the integrative approach. So I presume that, again, being a patient centric and the patient knows about their comorbidities half of the time. And even if they're not, the integrated approach being in the private is also being very much facilitated and highlighted in the TB approach in terms of the holistic care, which we all.
Yeah, thank you, Neha, for bringing out all these points. Now we have heard everybody. Now it's the time to respond. So if there is anything that Obioma you want to respond to Erlina or Neha, you can respond now in a minute.
Okay, thank you so much. I think for me, I just feel that when we talk about referring symptomatic, we are also trying to ensure that we loop in those people who they identify as being presumptive. So the topic is not saying that private sector is excluded from offering TB services. It's talking about you are engaged in the aspect of ensuring that these presumptive are referred to the public sector. Now, in the public sector, there are so many things in the public sector which would help us, give us the basis for this. When there are new things to upscale, the country is taking up a global communication that is upscaling and all that. It's very easy for us to go from the minister's office straight into all the state ministry of health and down to all the facilities. You will now come to start deciding exactly how to start engaging the private facilities to pass this to them. That assimilation doesn't happen immediately the way it happens in the public sector. There's still some gaps. So it now determines on, and we need to talk to the MD to get to this and that. And that's why the engagement of a private sector, like I said, it's because of what it has, is a gap filling it's doing for the entire health sector. That's the role they are playing. So you see there's a pause in passing through that upscaling of a particular thing adopted in the country. This thing should go like this for the patients and all that. So for the public sector, it's easy to just pass through. And that's why referring those presumptive to these places where both the bureaucracy, the communication and all that, it's already streamlined in a way that it's easy to pass.
Yeah.
And the patient immediately would start taking up with whatever it is that is being that's being changed, or whatever it is to help better their outcome. It's easy to pass it. But when you have done in the public sector, we now start engaging the private sector for that. And everybody has their own engagement modality. There's no one one size fits all, where you say, okay, let me just communicate to the private sectors. You start doing it in batches. For these people, you need to meet their MD. For these people, you just write a mail. For these people, you have to go through the association of. So all those things, and that's why we say referring the preventive.
We understood the challenges in engaging the private sector, because private sector is not organized. It's a bit fragmented. We understood the perspectives of the program manager. Nikorote, anything else you want to add here for the comments which they have actually made on the Fund Mother Act?
All right, great. So, well, yes, we are. It's very important that we agree that honestly there are different scopes that we approach towards referral. There are those who can, yes, effectively screen and refer, but those, the symptomatics, but those, we also need to recognize that, as Nea and Alina said, there are those who have the ability, and the private providers that have the ability, and we have active engagement with them that we that can, you know, manage. But sincerely speaking, in a resource limited setup where we do not have all equal access, and even engagement of the private facilities is limited, different task mix for different providers then should be employed, or rather a balanced approach is what I am saying, so that we effectively can capacitate everyone to manage TB within the both public and private frameworks that we do have. Because then if we don't, the collaborative efforts that usually are there, then we may end up losing them. And then, of course, the innovations that do exist within, yes, the private provider.
Thank you so much, Nikorote, for bringing out these terms, like there is scope for engagement and the challenges we have, but we need a collaborative approach. That's what we are also coming to. Yes, Erlina, it's time for you to respond if there is anything that you need to respond.
Well, okay, in the condition that private sector or private provider are not able to give the good dot services, I think, yes, probably we can develop or establish the public-private mix that are customized to any condition, that customized to the situation of one region. So it cannot be done in every situation. So yeah, I think I agree that we should deploy this public and private mix, but please make it in a what do you say it? Well, okay, in the comfortable algorithm that can be accepted by everyone, accepted by the private provider, accepted by the public provider, and also accepted by the government. Well, it is probably difficult to please everyone, but at least we can make convenience for our patient.
Yeah,
TB.
Thank you. Again, thank you so much, Erlina, for saying that yes, public-private mix is that we are actually looking for. At the same time, we need to check the concerns of the private sector and address those private sector. Neha, anything which you want to respond? Then we will look for some audience responses.
I think most of our people have already said, because coming to the point of it, and as I said in the beginning also, the whole idea of about this debate is to bring out the best of it. So because we are working on the public-private mix, this network is all about that. And we always say that more engagement, more collaboration towards the elimination. So that is the ideology is all about. So whatever concerns and whatever constraints, both the private as well as the public, because the whole idea is neither a single TB patient should be missed. All the patients should be receiving the care in the most optimal based environment, as we have been all advocating since almost in half an hour. And the third important thing is the right approach, right time, right diagnosis to the each and every person should be provided. So whatever the private is lacking in this is sometimes the uniform accessibility and uniform availability. through the collaboration, through the effective communication, if we are gonna mix that thing and that delineated pathway gets dissolved, I think the whole idea is the ultimate patient-centric approach, that whatever the patient decides, they should be getting the best of the things at the uniformity at each and every place.
Great message, Neha. What you have actually tried to bring out is, say, for example, there may be some lack of systems in the private sector, which in collaborative way we can actually address, and so that patient-centric care could be provided. I'm seeing few responses from the audience. I think we should give some time to the audience or the participants here. They are also experts here. Edwin, I'm giving a 1 minute to you to express your thoughts. Edwin Daru. If you can just unmute and talk to yourself. Yes, please, go ahead.
Okay, thank you for your time, Dr. Ahis, Dr. Deha, and Dr. Prof. Erlina Buhan. My name is Edwin. I'm from Indonesia. I'm clinical officer public parametrics from Indonesia. I implemented the TB program in Indonesia. I have experience one of my patient in Yogyakarta. He's a student in university, come from other province, and he study in Yogyakarta. On some time, he got a TB symptom and diagnosed by the private facility in a university. After that, because lack of the resource in the clinic in the university, and the university clinic refers to the other health facility. But unfortunately, the student is not go to the refers health facility and prefer to go back to his village. But due to the lack of resource in his village, after 2 months, the patient died because he not go to the reference hospital. What the lesson learned that I can get from this experience? If we refer the patient from the first to the reference hospital or public, the problem is most of the patient, they will not go to the other facilities because what? Because the delay of getting treatment, because it's huge problem in TB also, and other things some of people have the preference of his health facility. Like in Indonesia, for the public facility, there's a lack of the limitation in services. Like it's only open in from morning until noon. We cannot go
Okay.
for seeking care in evening or in afternoon. So for the private facility, we can go anytime, 24 hours. So that's, I think, the opportunity, because a TB patient cannot use that I should seek care in the morning, but we can go anytime. That's why
Got it.
I think we should push that the standard. We should make the standard for both public and private. It's similar because people have the preference of the health facility, and maybe that's
Got
the
it.
thought that I can share. Thank you.
Got it, Edwin. It's much clear, like what you are trying to make out is saying patients are going to the private facility for multiple reasons. The reasons is not that they have money with them, but maybe poor people are also going to the private sector for various reasons. Like you mentioned, maybe for convenient timing, maybe they can see the same doctor every time, maybe that they don't need to wait in the queue. So, there may be multiple reasons why patients are going. And all of us are saying in the same way that it needs to be patient-centric, and patient need to decide where to get the treatment from. But at the same time, the concerns from the program managers are also genuine, and they are saying the patient should not be lost to follow up. The patients need quality care, or what we call as the standards of care sort of stuff. So generally, what are we agreeing to from all the statements is like patients needs to decide where they need to get the treatment from. There is no doubt about that, because it's the patient who is going to decide. Patient-centric means patient is the VIP in this entire business. But at the same time, the concerns of the program managers is that they need to receive standards of care available in the country. So wherever they are, irrespective of whether they are getting treatment from the public sector or private sector, they need to get the standards of care. That's what we are all agreeing to. But at the same time, private sector has some limitations. That's what we have heard, especially systems for tracking or systems for initiating, identifying loss to follow up. So there are some systems which are lacking in the private sector. The other concern raised by the NTP managers were about the out-of-pocket expenditure that the person need to put in place. So we have solutions. So we all called all these as problems. Problems are called problems because we have solutions. Otherwise, we need to call them as fate. It's not fate. We are all discussing only about some few problems, and we have wonderful solutions. Petra, maybe do you want to say, because the collaboration is the key term that's actually coming up in this entire discussions as a solution for moving forward. So you want to talk about something here, Petra?
Absolutely. I think you summarized it beautifully. And I realize that our wonderful debaters are not very fixed in their own positions. They are already so open-minded in collaborating and being engaged with each other. And that is the whole point of, I know that I put champions of PPM on the spot instead of those that are fully set in their own minds. But there are still so many pieces that we need to work out. And thank you for the audience for asking some great questions and putting your hands up in the chat. I wanted to just close off by showing you one slide that reflects maybe where we put out the scenarios in the very beginning. We also now have some of the solutions that we actually heard about, and I thought that you might want to see just what some countries have been doing in together or putting up some efforts to collaborate. And so let me just, if you can see this one slide, I hope that you can see.
Yes, Petra, we can see this.
Okay, perfect. So this is a place where when the person with TB symptoms actually seeks at the healthcare provider, several countries have put transport mechanisms in place where there are mechanisms to a TB public lab or a private lab where there are couriers in place that are collecting the sputum samples from all kinds. In Nigeria, it's at the PPMVs, and which is the drug sellers from chemists or from smaller facilities, or in Pakistan, there's a large network where also from private physicians, sputum samples are being picked up that then go to the lab, and the results are being then fed back to the healthcare providers with support and mechanisms of ensuring that the notifications will happen. There are, in some cases, apps and electronic reporting mechanisms that facilitate private providers, which is a really important thing because the administration is where it often hampers amongst private providers. Then often this can be followed up by having the public goods, so the free TB treatments, being then first initiated from the government. The government is the ones that has these drugs, but they are then being supplied to the private providers or through the private providers, where patients can either pick it up themselves or they get directly from their private providers support. So there are mechanisms in various countries, and I know our program managers would be much better placed to explain how these particular function within Indonesia. I know Erlina is involved, Neha is involved in India. Obioma can talk for a long time about how wonderful the mechanisms in Nigeria are, and as Nikrota can speak to the various mechanisms in the districts in Kenya. And I thought, just to close us off in this long debate, that there are some excellent examples of collaboration that are being financed. And yes, as you said, Rakesh, problems are there to be solved, and there are plenty of problems that are still remain in making sure that we do provide the primary care at the primary care level where people actually seek care, and to make sure that we have coverage in the whole country. And that is, of course, universal health coverage that we're all seeking for, that actually support our patients. And with a patient-centered, people-centered care, that's where we want to end up. And that is our common battle. So
yeah, thank you, Petra, for that, bringing up that that summary very, very well. So I have also learned a lot. I mean, we have 6 more minutes remaining with us. So before we want to hear from all the panelists once again, so I have also learned a lot. I will take a minute to summarize what I have learned today. Basically, what I personally believe is that when we call as public sector and private sector, we also need to think that there is no private mycobacterium tuberculosis, no public mycobacterium tuberculosis. So there is only one mycobacterium tuberculosis. And patients, again, it's very difficult to classify as public patient and private patient, because if you look at, as Erlina said, patients are not robots. So they move, they move at their own willingness, they move. Sometimes patient may visit public sector, then go to the private. If you clearly look at the pathway, Erlina also mentioned that within the public sector, there is a private sector. Within the private sector, there is a public sector also. So we need to, the definitions, delineations are not that easy for public and private generally. But concerns of the program managers are very genuine in the sense like they have concerns regarding the fact that patients need to receive standards of care. Standards of care is something which we are actually looking for. They need to get the right diagnosis, right treatment, right follow-up, right public health actions, and right reporting of the outcomes and linkage the social welfare services. Standards is something that we are really need to focus on. And their concerns about engaging private sector is that private sector is not organized, it's actually segmented, and program manager has difficulty in reaching out to the private sector with of limited capacities. But at the same time, if you look at the private sector as such, they are willing to collaborate, that we have actually seen. They're willing to collaborate because it is their clients, it's their patients. Improving standards is always a welcome move by all the private providers as such. They are willing to collaborate. Only thing their request is that hear us also. We also have some concerns. Don't make things complicated. Let's make things very easy. And what the key word that we are discussing between both sectors is trust and coordination. Let's talk. Let's trust. Let's talk. Let's coordinate. Let's collaborate. Make things very easy. Let's make it, both the sectors, we need to collaborate for the patient or for the person affected with tuberculosis. That's what we are actually looking for. There are various models. There are various ways of collaboration. One size shoe may not fit all, but it's very easy to solve these problems if both the sectors are coming together for the society with a shared outcome. With this, I am stopping. But again, for the last summary, I am just leaving to our panelist. Maybe Nikrote, we'll start from you. What is your summary take home from today's debate?
Thank you very much. True, we are agreeing that private providers often serve patients who may not seek care in the private facilities, and due to, of course, stigma, convenience, and what you rightfully said, trust. So limiting their role to referral only may just exclude a significant population from accessing care. So it's very important then that we strengthen the public-private approaches so that at the end of the day, our focus is towards ending TB. So referrals to the public sector will ensure standardized care and maybe effective monitoring and outcomes, as you said. But it's very important, again, that we have this dynamic and balanced approach where we can capacitate everyone to provide services to the patient and quality services to the patient, of course, within the accessible PPM frameworks. Thank you.
Thank you. Thank you, Nikrote. Over to Neha for your summary.
Right. So I think the 4 keywords which I want to say for every one of us is engage, empower, collaborate, and then eliminate. So the whole idea about is that as we said, that if we have a standard of care maintained both in private and public, the capacity building, of course, coming from our program managers, we understood the points which you want to highlight. And that is very important because it's a public health disease as well. So if these 2 things are taken together, I think the path seems very right to me.
Great. Over to Obioma for your summary. Thank you so much for all these summaries.
Okay, thank you so much. And I'm also excited for the meeting and debate today. I think it did one thing. It kind of elaborated more, everyone trying to say what I have done better and what can be done better. So I think those are the strong points we will take, and within our countries also see how to reflect the same things. I also feel that both private and public are collaborative, and everyone is trying to meet the gap each of them may have. And it's a good thing and a plus if it works well, that collaboration. So we'll keep strengthening the collaboration and ensuring that it works well for the sake of our patients. Thank you.
Erlina, for your summary statement.
Yeah, thank you. I like the word collaboration. And I agree, fully agree, 100% agree. But please make it easy and comfortable for everyone. That's one thing. Second, we always say innovation is needed for diagnostic, for treatment, new drug, new vaccine, new diagnostic tool, using technology and innovation. But we don't talk about innovation in PPM. So let's create innovation in this PPM business. Do not do business as usual. I'm talking to myself, to Petra, to Rakesh, to Neha, to Kirote, and also to Obiama, and to everyone. Thank you.
Thank you so much, Erlina, for that point. Let's look at innovations. We have actually seen, I'm personally a fan of private-led initiatives coming up in multiple countries where private sector is coming forward. They are organizing themselves and helping themselves for improving the quality of care. At the same time, supporting the government, both the sectors joining hands for the support of people. Systems is a key word that we have actually listened. Strengthening the systems in the private sector. That's what the private-led initiatives are actually trying to do. I am seeing such models in various countries. That's all from my end. Over to you, Petra, for your summary and wrap up.
Thank you so much. Thank you to our wonderful panelists. I couldn't have summarized it better, Rakesh, and each of you with your individual statements. It's been very enlightening to hear you. And collaboration, engagement, and innovation is definitely something that we will need to take forward. Thanks, everyone, for joining today. We will put a report together. The recording is available. It will all be online. Erlina, did you want to say one more thing, or are you already waving? You're already waving. Okay, so thanks, everyone. We're 1 minute over time. Thank you so much. I really appreciate this debate, and wonderful weekend, and see